Okay. I have disclosures. I have received funding from a grant from Cerebell, but I will not be discussing that in this presentation. So learning objectives. First, seizure forecasting in hospitalized patients and the duration of monitoring, and then briefly into a very complex topic called the Ictal Interical Continuum. All right, so we covered this a little bit already. So when digital EEG started to develop in the 90s and the early 2000s, there were many studies that kind of looked to see, well, you know, if you look at patients who have some kind of paroxysmal clinical event or patients who had altered mental status, you know, what is the percentage of these patients that have seizures? And, you know, the initial studies probably had a bit of selection bias. There was, you know, astute clinicians deciding who needed EEG and who didn't. But now we have some bigger studies from some centers that use a lot of EEG. You know, just about everybody who has some degree of altered mental status gets hooked up. And here's the graph below. You can kind of see, you know, it varies to some degree based on etiology, but I think I can use this. I don't know, that's kind of hard to see. You know, here are the various etiologies, and in the blue line is the incidence of any seizure, and the red line is the incidence of status epilepticus. So you kind of take all of these patients together, and you get about 11% of patients that get hooked up have a seizure, about 4% have status epilepticus, and around a third of patients have some kind of rhythmic or periodic pattern, sometimes within this concept of the IIC that would necessitate further EEG monitoring. And a study by Dr. Clausen and Dr. Hirsch from Columbia really early on in the course of this clinical research found that most of the patients who had a seizure on EEG never had a clinical event that would have been suspicious for a seizure. So this is important. If you want to detect these patterns, you need to use EEG. You're not going to be able to just look at the bedside and say, oh, this patient has nystagmus, this patient has a little myoclonus, or something like that. You're going to miss a lot of patients who have seizures. And you know, we talked about this a little bit already, but you could argue, well, maybe we don't really care. If patients have a few seizures, you know, we've been taking care of patients for a long time before we figured this out, that many of these patients have seizures. Maybe it doesn't really matter. Maybe we don't need to detect them. And here are a couple of studies that would suggest there's at least a dose-response relationship between the incidence of seizures and poorer outcomes. So this study from Columbia, an aneurysmal subarachnoid hemorrhage. What they show here is this is modified Rankin scale 4 to 6. So the more seizure burden you had while you were hooked up to EEG, the more likely it was that you would have a poor outcome. Similarly, you would have a poor cognition. Here's a pretty well-known study by Dr. Payne and colleagues. What they show here is that it's not only the overall burden, that there seems to be some degree of like an intensity of the ictal pattern. So what they found here is that around 20% of any given hour, if there was seizure within that time period, those patients were more likely to have a poor outcome, and independent of the etiology, so acute seizures, acute brain injury, or systemic disease, and this red line are basically patients who would have a poor outcome. So once you get to about 20%, there seems to be patients who are more likely to have poor outcomes. And then there's been pretty well-developed literature looking at the consequences of status epilepticus in terms of like generalized atrophy of the brain. Sarah Hoker published a study not too long ago, and especially hippocampal atrophy. If somebody's in status for a long time, you often see these DWI changes start to occur in the hippocampus, and then over time you can eventually see atrophy. But as Dr. Schmidt really presented quite well, how can we possibly scale this technology to meet the demands just within the United States, just within highly resourced academic centers? We struggle to do this. Think about rural places or places with many fewer resources. We need some kind of techniques to figure out how to triage these resources in the best possible manner. And one of the original studies that tried to figure this out was another study from Columbia. And what they did is they took 110 patients who had had a seizure, and they looked to be how long did they need to be on EEG before that first seizure was detected. And they figured out, basically 24 hours if they weren't comatose, 36 to 48 hours if they were comatose, to capture about 95% of them. Then we thought, maybe we could do a little bit better than this. So often in patients who have seizures on EEG, especially these ICU patients, we've all had patients in the EMU where they have temporal lobe epilepsy, they're on monitoring 3 days, their EEGs look completely normal, we take them off drugs and you see a temporal lobe seizure. And then you start to see some interictal discharges. But often these ICU EEG patients, it's not really like that. You'll see an epileptiform abnormality or something along the spectrum of what we consider epileptiform, and then they'll have a seizure. So maybe we can use this technique to figure out, okay, they've been on monitoring for a certain period of time, we don't really see anything epileptiform, maybe this is a low-risk patient. So this is a study that Dr. Gaspard developed. So he took 665 patients who had been on continuous EEG monitoring and marked the first epileptiform abnormality and the first seizure. And then we risk stratified by 2 clinical factors that are fairly well known to be associated with seizures. So as we saw in the prior Clausen study, patients who are comatose, they tend to have need to be a little bit longer on EEG before we necessarily rule them out as not likely to have seizures. And if anybody's had any kind of clinical event, whether that's a history of epilepsy or some event suspicious for an acute symptomatic seizure, of course they're going to be at slightly higher risk too. So if you risk stratify based on those, you can figure out, what is the proportion of these patients that eventually develop seizures, how long do they need to be monitored before they have an epileptiform abnormality or before they go into the absorbing state here of a seizure. And from this, you can figure out how long do they need to be on monitoring, and that's what these lines are. This is a multi-state survival analysis, it's called. But I'll put it in writing so it's a little bit easier to interpret. So basically from this study, we could figure out that if you weren't comatose and you didn't have a history of seizure, you needed only about a routine EEG to figure out that that patient's at very low risk of having seizure over the next 72 hours. If they had any of those clinical risk factors, you needed about 24 hours of monitoring. And if they had an abnormal EEG in addition to any of those risk factors, you actually needed to monitor them for a couple of days before you were pretty confident that this patient wasn't at high risk for seizures. And I think we're a bit adult-centric here, so I wanted to highlight one of Franz Fung's studies that's tried to look at this similar paradigm in children. And what she has found, so she did something very similar, a multi-state survival analysis. She's a bit more concrete in how she defined the EEG risk states. So if you had any of these factors, which I'll talk about a little bit more later. So things that are, I think, pretty well accepted as being associated with seizures. And if you had clinical risk factors, so a prior clinical seizure again, but age less than 1 or greater than or equal to 1. So it really seems that she found that the neonates were really at high risk for seizures and needed to be monitored a bit longer. What she found is that for the most part, kids needed to be monitored for around a day or 2. Very few could be monitored for less than that. So while there are fewer children that need this monitoring, in general, they need to be monitored longer. But then there was a nice study by Dr. Rodriguez from Emory, and he thought, we call all of these things epileptiform, but are they all really created equal? Some things may be more associated with seizures than others, and maybe we can leverage this idea to kind of even enhance our risk stratification a bit more. So that led a group of us from the Critical Care EEG Monitoring Research Consortium. They had developed this very large database from that time from Emory, Brigham and Women's, and Yale. They pooled all of their clinical EEG reports and had very good markings and what findings they had, when the seizures were. And we thought maybe we can use this data to develop a tool, something like the CHADS score, something like that, to help us figure out which are the patients who are going to be at greatest risk. And at that time, they had around 5,427 continuous EEGs. And we used this machine learning algorithm that's really specifically designed to optimize these kind of clinical point scores that we often see in medicine. It's called Risc Slim. Then we did this technique of cross-validation to make sure that it would be regularizable. And we looked at 24 different clinical and EEG variables. And what we developed is this score called 2 helps to be, and that frequency of greater than 2 hertz of any periodic arrhythmic pattern except generalized rhythmic delta activity. in general, and this has been called FIRDA in the past, so frontal intermittent rhythmic delta activity. That's a finding that doesn't seem to have really much association with seizures. You know, it has other pathophysiologic implications, but not really on the spectrum of the IIC or independently associated with increased risk of seizures. And then independent sporadic epileptiform discharges, so you know, your generalized spike wave, your focal spike, any of those kind of patterns, you know, for a long time we've known that they're associated with seizures. That's a risk factor. And then there's the lateralized periodic discharges, so that's been called PLEDs in the past, so periodic lateralized epileptiform discharges. Those are interchangeable terms. Bilateral independent periodic discharges, so you know, you have periodic discharges, but they're in both hemispheres, and sorry about that. But they seem to march to the beat of their own drummer. And then there's this concept of lateralized rhythmic delta activity. So this is if you have something, you know, less than 4 hertz, if it goes on for more than 10 seconds, we call that lateralized rhythmic delta activity. It has been associated with temporal lobe epilepsy, you know, prior to the development of the ACNS nomenclature, but it was called temporal intermittent rhythmic delta activity at that time. Then we know for a very long time this idea of PLEDs plus. So you have a periodic discharge, and then often on the descending limb, you'll have this rhythmic activity or you'll have this fast activity. That pattern in and of itself can evolve into seizures, and you know, independent of that, it has a higher association with seizures. So PLEDs plus have been known for a long time, but even if it's associated with, you know, generalized periodic discharges or lateralized rhythmic delta activity, any of these kind of plus features make that pattern higher risk to be associated with seizures. And then if you've had a prior seizure, and if that's, you know, association with epilepsy, or as I said before, an acute symptomatic seizure, that places you at increased risk. And then there's this idea of BIRDs or BRDs, so brief, potentially ictal rhythmic discharges. These are patterns that look very much like seizures, but don't really meet that 10-second criteria. So they're, you know, almost like proto-seizures in a sense. And because they're so highly associated with seizures, they're the only ones that would actually get you 2 points. So you can add up, you know, how many of these findings that you have, and it gives you an idea of the risk of a seizure on a continuous EEG. And the way that you evaluate these algorithms is something called a risk calibration plot. So here on the vertical axis is the percentage with seizures, so this is the ground truth. This is the predicted seizure risk, so this is what the algorithm predicts. So a perfect risk calibration model would approximate this dashed line. And this is our algorithm here, and each of these dots represents a different category. So this is 0, 1, 2, 3, 4, and the numbers are the number of patients who were in this initial study who are within each of these risk categories. So I think the utility of this is really down here. You know, as Dr. Schmidt said, we just can't scale up our technology to meet the potential demand. But we find here that there are quite a few patients who are hooked up to continuous EEG who are ultimately fairly low risk. And those are the ones where there's a potentially quite a bit of savings. And another way of looking at the classification utility of an algorithm is called a receiver operator characteristic curve, and you measure the area under here. 0.5 would be a null classifier, and we're at 0.82, which is, you know, pretty reasonable for these kind of models. There were some issues left on the table with that first study. You know, we didn't really define how long of an EEG you needed to accurately calculate this score. We didn't standardize the prediction window, and we wanted to look at an independent set of centers, because these were, you know, 3 centers that had been that had very well advanced in this technology, so to speak. So we found 5 different centers: MGH, a hospital in Brussels, Emory, Duke, Medical College of South Carolina, and the University of Wisconsin. And we found around another 2,000 patients and recalculated the score. So the validation here is in green, the initial study is in blue, and you can see again, they approximate this dashed line pretty well. And then we thought, you know, it's nice that there are all these different numbers, but practically speaking, let's figure out what are the actual useful clinical cut points that, you know, could help you change management. And we thought, well, there's this low risk group. That's this 2 helps to B score of 0. There's a medium risk group. And then really all the patients who are higher than that, it's not as common and we could probably lump them together. And then we did survival analysis based on this, based on calculating the score within the first hour. And from that, we figured out how long do these patients need to be monitored based on these 3 clinical groups. So the low risk group, this score of 0, they only needed to be monitored for an hour, and they were already less than 5%, around like 3% actually. And then this medium risk group could probably get around 12 hours, and they're less than this 5% threshold. And then this high risk group, you needed at least around 24 hours. And this high risk group, they often have some of these patterns that are on the IIC, probably need empiric drug trials anyway. So it's really these kind of 2 other groups that maybe these are the patients where we don't need to utilize as much continuous EEG. This is just the risk calibration based on calculating the score within that first hour, excluding anybody who had a seizure within that first hour because they've already declared themselves. And you can see it's actually approximate the calibration, the ideal classifier or risk calibration plot even a little bit more. So from this, you have an idea of the overall seizure risk, the false negative rate, and how long you would need to monitor them. So from this, we proposed a clinical algorithm, so hospitalized patients with altered mental status or a clinical event suspicious for seizure, do this hour of screening EEG. Of course, you want to try and minimize any sedation, propofol, midazolam that may be suppressing some of these abnormalities. Make sure that you've figured out that this is the optimal EEG to try and calculate the score on. And from that, you can kind of go through this algorithm and figure out who needs to be monitored and for how long. The problem with this algorithm when I tried to implement it at my hospital is EEG technologist time. So you have somebody go hook up an EEG, they have to monitor it for around an hour, so now you're already talking about an hour and a half of time. Then, if they feel very comfortable and they're very well trained, maybe they can make that decision on their own to convert to a continuous EEG. But if not, they have to call a fellow or an attending, so that takes them 10, 15 minutes to get back. So you've eaten up around 2 hours of technologist time. And we've already heard this is a very valuable resource in just about any center. So are there ways that we can implement this with still minimizing the amount of EEG technologist time? So we'll talk a little bit more about that later with Dr. Zubayda's got some interesting things to discuss. Now here's another question that I don't think has been entertained quite as much. So we already looked at some of the guidelines that were published in 2015 on how we should use continuous EEG monitoring. And one thing that's always come up in clinical situations for me is, okay, the patient had a seizure. Now they've been on EEG for another 24 hours, 48 hours, 72 hours. How long do they actually need to be monitored? And our guidelines say for at least 24 hours. And that was based on this study by Dr. AAN where he surveyed a bunch of neurologists and kind of said, well, I bet it's about 24 hours. A few said maybe 48 hours. A few even said 72 hours. Some people, a bit more cowboys, maybe didn't need too much. So I thought maybe we could look at this a little bit more. So this is a study we're working on now. So these are a bunch of University of Wisconsin patients, 117 who had experienced an electrographic seizure. And then we lumped them into clusters. So if you had any number of seizures within an hour, we kind of said that that was one seizure block. But once that stopped, then we would start a survival analysis plot and look at all the times that happened in each of these patients. And then, censor it based on when the EEG was withdrawn. And we had 187 different seizure time to event data points basically to run survival analysis on. And then we looked at covariates. So what are, did the patient, were they in status? Did they have a number of, did they have 8 seizures versus just 2? Was a new anti-seizure medication added? Were they on IV anesthetics? Were the IV anesthetics just recently withdrawn? What about some of these other patterns that aren't quite, status, but maybe would suggest that they have an increased risk for recurrence of seizures? What was the background, burst suppression, generalized slowing? Really, none of those things turned out to be significant. The only thing that mattered is if they were in status epilepticus. Those patients were at higher risk for seizure recurrence, which I think follows most of our clinical intuition. This is just a swimmer's plot of this data. So the green means that the EEG was stopped without another seizure happening, and the red means that there was a seizure, and wherever the line is, that's where that seizure was. You can see that the seizures cluster quite a bit lower than the green. And if you look at how long they needed to be monitored before they had about a 5% chance of having a recurrent seizure, the experts were pretty close to what we found. It was about 25 hours if you took all comers. If they had a history of status epilepticus, you needed 36.8 hours. So, a day and a half, a couple of days if they were in status before you felt really comfortable that it wasn't going to come back. And this is just the same graph with the status patients in red and the no history of status in blue. So, and if you excluded the patients who had status, you actually only needed 21.4 hours. So still about a day for your general patient who had a discrete clinical seizure or electrographic seizure, but a couple of days for somebody who was in status. All right, so now we'll move on to what is this ictal interictal continuum. So one thing I kind of want to stress is, what does this IIC mean? Basically, it means that there's a pattern that in and of itself doesn't meet what we consider like canonical criteria for a seizure. But sometimes it behaves like a seizure. So it's possible seizure or status epilepticus. That's, I think, a helpful way of thinking about it. And in the recent ACNS nomenclature, they really did a good job trying to define this a bit more. So any periodic or spike wave pattern that's over 1 hertz but less than 2.5 hertz and over 10 seconds, that's considered ictal interictal continuum. Any periodic or spike wave pattern that averages over or like equal to, or I should say greater than or equal to 1/2 hertz and has a plus pattern associated with it or fluctuations, that's considered IIC. And lateralized rhythmic delta activity that's over a hertz and has plus modifier fluctuations, that's also considered on the IIC. And then it does not qualify for electrographic status epilepticus or an electrographic seizure, and these were further defined. So an electrographic seizure is epileptiform discharges that are over 2.5 hertz for over 10 seconds, and any pattern with definite evolution that lasts over 10 seconds. An electrographic status epilepticus, now we had seen earlier that there seems to be this inflection point that over 20% of any given hour that has seizure in it, it seems to be associated with poor outcomes. So now we say that, if you can find any hour within that EEG where over 20% of it is seizure, then that's status epilepticus, or if you have more than 10 continuous minutes. So here's a metaphor for the way I like to think about the IIC. So if you buy a suit coat, this is what they'll tell you. You're always supposed to button the middle button. This is like a seizure status. You always treat that, right? Now, the bottom button, it's there, but you're not supposed to button it. That's the trick. So what's really nice with the non-IIC rhythmic or periodic patterns, I think for a long time, we were like, I don't know, do I treat this? Do I not treat this? The 0.5 hertz, static LPDs, do I do anything with it? Now I think we feel pretty good that these are patterns that don't need to be treated. These are patients that don't necessarily need to be monitored longer than you would suggest for just their overall seizure risk, not specifically for like empiric treatment trials of an IIC pattern. And then you have this top button where it's dealer's choice. This is the ictal interictal continuum. This is the one that's possible status epilepticus or electrographic seizures. These are the ones that maybe you treat. And let's see if I can get this to work. All right, it worked. So here is a patient who has 1 hertz periodic discharges right in the lower right-hand hand quadrant. And associated with each of these jerks are myoclonic movements. So this is electroclinical status epilepticus. You have a pattern, you have a clinical correlate, that's electroclinical status epilepticus. But this pattern in and of itself, I don't know, it's a little bit on the bad side, but it's nothing like this. This is a patient who has 2 hertz lateralized periodic discharges with some of this fast activity intermixed with it. So this isn't status epilepticus by electrographic criteria, but this EEG is much worse than this EEG, at least to my eye. So how do we kind of make some idea of what's going on here? We can say that the EEG is worse in one patient, but we're not as concerned, but the other one's in status epilepticus, and we need to, dramatically treat that. Is it really a difference of the underlying neurophysiology, or is it because of, our biases with scalp EEG? We know scalp EEG is a very biased test. It only looks at a certain part of the cortex. There's different orientation of the dipoles. If this is coming from the insula, often you don't see very much. If you put in probes, you'll see that there's a lot more fast frequencies in many of these areas. Maybe some of this is a response to an underlying more like canonical electrographic pattern. Is there some bias from our EEG that is just limiting our perspective on this? Is it, just because something is near eloquent cortex, so we're more concerned about it? Are we right in that regard? Maybe this is just as likely to damage the brain as this. So this leads to this idea of the ictal-interictal injury continuum hypothesis. And it's not really clear that it is a continuum. Maybe this is more binary than we think. Maybe there are just patterns that are bad and ones that are benign, and we don't necessarily, and we just need to really, hone in our skills, do more studies, and we can figure out, this is the bad one, this is not. Or maybe it really is a continuum. Maybe there's different thresholds within different patients. If you have an impairment in autoregulation, then 1 Hertz LPDs does become pathologic at some point. It has metabolic consequences that can't be compensated with because there's not enough perfusion. And maybe we need to think about them differently and really have a patient-specific approach. But so the way that this diagram is understood is on the horizontal axis, there's interictal and ictal. And what we mean by this is if I were somehow able to magically take away that EEG pattern, the neurologic exam improves, right? That's what we mean by interictal and ictal. And then here on the vertical axis, we have, does this pattern injure the brain? So potential for secondary brain injury. And these things, aren't necessarily independent of each other, but to some extent, they're not completely correlated. So up here, we have generalized convulsive status epilepticus. Nobody's gonna argue that that's not status, and we have the most data to suggest that this can cause secondary brain injury. Then you have in the lower left-hand corner, you have burst suppression or suppression burst. This is a pattern that really is an ictal and really seems to, if anything, potentially be protective of the brain. And then you have all of these kind of other things, and this is with some older nomenclature. And beneath generalized convulsive status, you have non-convulsive status epilepticus, non-convulsive seizures, and then focal motoric status or epilepsia partialis continuum. What evidence do we have that some of these IIC patterns can injure the brain? So we had seen some things from seizures. There seems to be this dose response curve, but this is a study by Dr. Zafar from MGH. And what she had shown is that even things that aren't necessarily seizures, but some of these epileptiform IIC type patterns, that there seems to be this relationship between maximum daily burden of these patterns and an increased risk for poor outcome. But as I'd shown in that study and in this study, there's a very easy way to say, well, I know that the primary driver of outcome in these patients is the underlying etiology. Bad hemorrhage, bad encephalitis, they're gonna have a poor outcome, but they're also more likely to have epileptiform abnormalities. So how can you tell me that these epileptiform abnormalities are actually adding onto what the underlying etiology is? It's nice to have a dose response curve like this, but you can have a confounder that would easily explain both of these factors. Do you have any direct evidence that these patterns in and of themselves can damage the brain? And we do have a little bit, and it's often termed the metabolic mismatch hypothesis. And this is the idea that we know that the majority of brain metabolism is related to glutamate cycling. So if you have a dramatic increase in excitation, you're going to have a big increase in metabolic demand in that part of the brain. And if we have a patient in the EMU and they have a temporal lobe seizure, if you hook them up to like a NEARS study and you look to see, what is the blood flow that occurs in that area during the seizure, you have, if anything, an excess in perfusion. So there's like luxury perfusion, like what you see in like the bold signal in an fMRI. Whereas in patients who have some impairment in autoregulation, they often don't have that luxury of excess perfusion. And if the pattern goes along long enough, then what you can start to see is a mismatch, and you can start to see DWI changes and secondary brain injury. And here are a couple of studies that have looked at this in a bit more detail. So this is a study of aneurysmal subarachnoid hemorrhage using an oxygenation probe in an area that was generating periodic discharges. And they show that there seems to be this relationship between the intensity. So like how frequent that pattern is, and I'm talking about like the hertz, like is it 1 hertz, is it 2 hertz? How many of those discharges are occurring in a second, and how long do they last? There's some equation between those two things that causes an increase in metabolic demand that will then cause a drop in oxygenation. And they found that there seems to be this threshold around 2 to 2.5 hertz. And that's what you're seeing here. There's a decrease in oxygenation as patterns that have this higher frequency as they go on long enough. So there's a study in TBI patients by Dr. Vespa, and he looked at microdialysis, so looking at other metabolic markers, and he looks at the lactate to pyruvate ratio, and again shows this relationship that when these periodic discharges are occurring, there's an increase in lactate, so another marker of metabolic distress. And here's a study that we did using FDG PET in these patients, and we similarly found that the frequency of these periodic discharges is associated with the local increase in intensity of the metabolic demand, in this case measured with standardized uptake value relative to the PONS. But what's kind of interesting is that the locality, or the focality, I should say, of the increased metabolism can vary quite a bit and is not always reflected on the EEG. So you can see this patient has very focal hypermetabolism, and they had just a little stroke in that area, and you could see, very well-defined LPDs. But then you see this patient, they have much broader area of metabolic demand, and often what you'll see is that it'll go into the thalamus, into the basal ganglia, and then often into the hippocampus, which suggests one of these mechanisms of secondary epileptogenesis that we often see in patients in prolonged status. And there's a fairly linear relationship between the frequency of the periodic discharges and the SUVR. And there's a relatively recent study from Hopkins looking at a very similar idea with FDG PET on patients who had been on ICU EEG. They had found, again, is this relationship to frequency. They also saw that the morphology of the discharge, if it was more spike-like, that suggested greater metabolic demand. And importantly, they also found that this plus modifier, this modifier that we associated with increased risk of seizure, that also seems to have independent metabolic consequences. So that led to kind of a rethinking of this Ictal interictal continuum hypothesis to some extent, that maybe we should be looking at metabolic markers, or either with PET or DWI with MRI, or even CT perfusion. That's a better way of trying to delineate what's going on in these questionable patterns, explaining why sometimes we see EEGs that don't necessarily look as pathologic but respond well to medications, and seem to behave like seizures, where sometimes we see patterns that even look a bit more aggressive and they don't. So here's just a few examples. So these are periodic discharges: left temporal, left parasagittal, right parasagittal midline. So you see these lateralized periodic discharges, but clearly not up to that 1 hertz criteria. So this would not be IIC. But LPDs, even if they're less than this frequency, are associated with an increased risk of seizure. So you may monitor them for 24 hours or so. Here's lateralized rhythmic delta activity. It's greater than 1 hertz, but doesn't seem to have any plus features or some clear fluctuations, at least in this short segment. So this is another pattern that's not IIC. Here's the generalized rhythmic delta activity, or sometimes called FERDA. So we said this is not IIC and is not associated with an increased risk of seizure. But here's this pattern that's 2 Hertz with these plus features. This is Ictal, interictal continuum. So this is a patient you would want to try empiric treatment trials. And here's one that I think is, even a little bit trickier. So it's kind of at that 1 Hertz, not necessarily over 1 Hertz, which is what they define for the IIC. I don't know that you would necessarily say that there's great plus features. So for a plus feature, right, you only want it to be there when the pattern is there, not when the pattern is absent. So, it's kind of right on that border and would be one that I think there would be a lot of discretion in how to approach it. So if you have one of these patterns on the IIC, what are you supposed to do next? And if there's a clinical correlate, as we already discussed, that's electroclinical status epilepticus, you treat it. I think most of us tried benzo or anti-seizure medication trials, and then you can try some of these ancillary modalities. So there's a recent study that really tried to define how we should go about giving these trials. We've been doing them for decades now, and I think every center, every person does it quite a bit differently. So you can either use a benzodiazepine or a non-benzodiazepine. When I first started doing this, I did a lot more of lorazepam trials. Now I favor doing levetiracetam or lacosamide, just because it's a little bit less sedating, and I think I get clear clinical responses. But often I think these things are relatively underdosed, and they came out and said you should be using 2/3 to 3/4 of a full loading dose of one of these medications to give an adequate trial. And what you want to see is that the IIC pattern resolves for at least a minute, and if it's intermittent, you want to see at least 3 times the longest segment where you didn't have the pattern. So if it happens only, if you had a IIC interval that only happened every 10 minutes, you'd want to see that it wasn't there for 30 minutes. Then you want to see that there's some clinical improvement and there's a clinical grading scale to suggest that the patient improved. If you want to use FDG PET, you reduce sedation, the uptake period is about 30 minutes, and you inject, and it'll give you really good spatial resolution, and you can see, to the extent that the hypermetabolism is. But this is very difficult to obtain in, I think, just about every center. I think what's becoming more common is using like an MRI and looking for DWI changes and perfusion changes. And this hasn't been studied quite to the same extent, but I think we're learning more and more, and there's efforts underway to try and figure this paradigm out a bit more. The drawback is that you have a much shorter segment that you're sampling versus FDG. And as we said, IIC means possible status epilepticus, basically. And there's a nice study by Dr. Kim and colleagues in 2021 where they looked at MRI to compared patients who had been in status versus patients who had just had a few discrete seizures. So basically, was the patient actively seizing during the MRI or not? And what they found is that the ASL, so arterial spin labeling, so perfusion, was a very sensitive marker to detect the patients who are in status, and DWI changes was a very specific marker. And if you're at a really lucky center, you can actually put in probes and you can look directly at the underlying neurophysiology. Of course, there's a lot of spatial sampling bias in these patients, and often you'll see things on these probes, if you have an EEG in there, that you won't necessarily see on scalp EEG, periodic patterns, discrete seizures, and now you're in a whole nother realm of what do you do with that. So here's an algorithm proposed by one of my colleagues, Dr. Halla, in how to approach these things. So if you have arrhythmic or periodic patterns, low risk, you monitor them for seizures, but otherwise you can discontinue the EEG. If it's an IIC pattern, you try an anti-seizure medication or a benzodiazepine. If you have a clear electrographic and clinical improvement, then you kind of go along that paradigm of following them clinically, following their EEG, escalating medications as necessary. Now, if you have an unclear response, this is when you consider one of these other tests. And if they're negative for ictal changes, you can probably follow them clinically or maybe repeat the test in a couple of days if they're not improving. But if you have positive for ictal changes, then that would be another indication to start escalating treatment a bit more. So just briefly a case A 67-year-old woman who had melanoma and a recent parietal lobe met that was resected, came in EPC that progressed to generalized tonic-clonic seizure, then was treated with IV benzodiazepines and emergently intubated, and then had altered mental status but no positive clinical manifestations. This is what the EEG looked like. So pretty aggressive looking periodic discharges, mostly on the left hemisphere, but some volume conduction to the right posterior quadrant, and associated with some of these plus features. So they escalated anti-seizure medications, completed more clinical workup that was unremarkable, and then attempted weaning. And then upon weaning, you'll see that, if anything, this fast activity that was associated with these discharges has worsened. And this is, as we've discussed, associated with increased metabolic demand, and if anything, makes this pattern more suspicious for being IIC. So a PET scan was performed, and you can see in the vicinity of the discharges, there was a great increase in metabolic activity. You can see this extension into the thalamus and the basal ganglia, and even into the hippocampus for something that was seemingly so focal. I always find this very interesting. So then she was given ketamine, which really seemed to decrease the amplitude of lateralized periodic discharges, decrease their frequency, and decrease some of this fast activity. So then just followed clinically. These resolved into discrete epileptiform abnormalities, and then she woke up and was able to transfer to rehab. And while LPD discharge amplitude in and of itself, if you look between subjects, isn't that useful, within a given patient, if you see the amplitude start to decrease, that is actually suggestive that the irritability is decreasing. But because of the heterogeneity and where they're coming from and the different dipoles, it's very difficult to compare between patients. But within a given patient, it can be somewhat useful. So in summary, I think we've discussed why EEG can be useful in hospitalized patients to quite some extent. Seizure forecasting, 2 helps to be on 1 hour of EEG, can be useful. For monitoring after a seizure, 24 is probably sufficient unless they were in status. And then we just discussed all of these IIC type patterns. EEG only sees part of the problem, and we really need to look beyond that for our complicated cases. And we need to tailor treatment decisions based on that specific patient. So here's some resources for those who are quite interested in this topic. This is a second edition of this book. It is really excellent. It has a lot of quantitative EEG in it too. Dr. LaRoche's book on ICU EEG monitoring should be by all of our reading stations. Really nice bullet point format. And then anybody who wants to be involved in this field should really be using the ACNS critical care EEG terminology. And there's a nice little training module with a lot of examples and a little test that can get you certified. And then here are a few select articles where people try and broach this quite complicated topic. So thank you to all my colleagues and collaborators in this field.